Yes, yes. Representing Latin America too. Maybe I am the only one from South America. Yeah, so it's very important for me to be here and with you guys. So hope you enjoy my presentation. This is very challenging case with maybe a different approach. Okay, so this is immediate implant placement in compromised class 3 socket. Maybe the title is so obvious, but the situation here has different challenge situation that we uh, change our mind about how we focus on that kind of process. So this is has a high smile line patient. The story of Marion is a good patient with referred to us with a difficult situation. As you can see in the picture, this is the high smile line with thin phenotype. So the situation is very challenging here because you know how thin phenotype behaves. So the point here is this is an endodontic treatment, and we focus on one in the 2.1. So, but the situation is more global because the aesthetic embrace the smile. So for us, the situation is that maybe, but for us, this is the article that we always put in our classes. It's about the different stages that we have to keep in mind in patient. It's about the compliance, for example, the story of periodontic surgery, the healing protocols, and the surgical experience. The implant related about the macro and micro designs, the timeline of the implant placement, the healing protocol, the loading protocol, and the soft tissue management, and of course, the biomaterials in the proper selection of this kind of biomaterials. So assessment is high smile line, for example, that patient, thin phenotype, high aesthetic demand, the soft tissue is an issue, the hard tissue too, and the prosthesis. So, okay, this is easy to maybe to diagnosticate, but the point is how we put that things in the timeline, the treatment. When I talk the timeline, because this is difficult, because how you manage that kind, because of what Buser told us that we can do early implant placement. But what happened with early implant placement? You have to wait 8 months, 8 weeks, sorry, and the healing of soft tissue, what happened with scar tissue, what happened with recession, with aesthetic, and the timeline and comorbidity of the patient. So for us, is why don't we think different, this kind of approach? What happened with recession too, and the aesthetic, okay? So this is the situation. We don't have bone wall here, and a granulation sheath tissue, that this is a chronic lesion. So for us, what thinking about how we can take this situation to another level. So for us could be a very user approach, ITI, I think, that maybe safety flap and elevate everything and put some graft material and wait 6 months and then the implant placement or immediate implant placement with GVR, early implant placement with GVR, but soft tissue maybe could take 2 years, that kind of treatment in the stage approach. Soft tissue, healing, GVR with implant placement, connection, and everything. So a patient with high smile line has different situations that we need to confront here. So for us, it's the situation. This is the European colon classification. I always put that classification because give me perspective of the 4th dimension that we need to keep in mind with this situation. About, for example, the medical story, it's a green flag for the patient because it's a good patient and put his mouth in, or the team, as a team, to believe in us, okay? But let's take a look about how we can find in local findings, for example. The healthy patient is age as a 1, okay, 2.1 chronic lesion, high smile line, thin phenotype, and class 3 alien. You know how demand that kind of treatment because of the gingival margin and the aesthetic. Okay, but surgical. Surgical, different approach. Every surgery has his rules about the time, his expertise, the risk management, okay? The younger are maybe more prone to take more risk, but the other one maybe have more experience or have more stage approach in that kind of situation, okay? But we need to face the GVR, the restore the bone wall, the implant placement in 3D position to have the soft tissue in proper thickness and gingival margin position. Multiple surgeries could be faced in that case. And restorative, one single crow restoration is very challenging to the prosthesis. The merge profile, the provisualization, and how we manage the stabilization of the contour of the gingival margin. Okay, so here is a maybe challenge situation in these three topics. Okay, 10 minutes. This is what I always put. This is the protocol of perioplastic about stage approach. We need to prepare the patient, do the EVR, maybe the implant placement, the soft tissue, prosthesis, maintenance. Okay, this is how we manage the complication management, the two cases before. But for us today, something different. This is a challenge situation here with you, all the competitors, maybe excellent cases. So I put things different. Okay, this is maybe Steve Jobs put that things in the 90s about things different or things outside the box. Okay, but maybe it was very important for me because maybe as an Aquarius guy, maybe I always go through the other direction. Okay, but things different for me is very important because how we can put all things together and do maybe something different. Okay, so I've been in 2013 with Dr. Da Rosa in Caxias do Sul, Brazil, with the tuber graft about immediate GVR. No, it's the name in English. Well, immediate gingival restoration. I don't know it, but Dr. Chu used in NYU the same approach with biomaterials. So the local finding is easy extraction, a traumatic extraction, under premedication of antibiotics, and the local management of the granulation tissue with the chemistry and cleaning all the socket. Okay, so here this is maybe the same approach ever, but what happened with the surgical? Maybe the surgical maybe is different because we do it immediately. Immediately, okay, we put the implant in the palatal approach, guided with osseoidentification. We know that osseoidentification increases the stability with the spring back effect and with apical and palatal anchorage. Okay, so that okay, but at the same time, we do it the gingival graft to increase not only the thickness, to mobilize the gingival margin to the coronal position. And why not to the lateral and to the canine? Okay, we use the modified tunnel approach with a coronal displacement, and then why not to use a socket preparation with GVR? We perform, this is from Stephen Shu approach in his book, and with Dr. Da Rosa approach with this kind of class 3 alveolus. As you can see here, this is a abutment that creates a space, and this is the membrane that we use. It's a collagen membrane, but very rigid and very easy to handle because it's not flexible, it's deposit. So you have time to put the membrane with these wings supported in the proximal tissue and create this space that we need to separate the soft tissue and the bone box. Okay, so now we use the membrane. As you can see, we create the soft tissue space, the membrane with the rigidity and the abutment, and we create this box to fill with bone. Okay, so now we fill it with bone, and why not again? Why not if we have stability, the proper 3D position, why don't we put the provisionalization immediately? Okay, so this is how we resolve the surgical, and why don't we go to this prosthetic? This is Alberto Gonzalez, the new article that he suggests the GVR space. We know that's subcritical and critical contour, but what happened with the regeneration space? So with that kind of abutment, we create the space, and the position of the implant goes more apically. 5 millimeters apical, because that abutment gives me 2 millimeters to support and to create the space for prosthesis and create the space for GVR. So now, this is the approach that restorative have to perform. This is with my friend Jonathan Esquivel. He suggests with Ramon Gomez Meda the passive full contour, active full contour, and subcontour provisionalization. So now we have to wait for the tissue to healing during the space. So what we do here, we use a subcontour provisionalization to support the tissue and give it the proper time to heal. So you can see the displacement more than 5 millimeters coronally. This is no time for restore the gingival margin, and we wait 3 months to have the maturity of the tissue again. The collagen is so important here to be compressed then. Then active provisionalization to give the same level of the gingival margin, but more important, to copy the same form of the gingival margin of the 1.1. So now, wait a little bit more time, and then this is the merge profile. Okay, so we check the merge profile because we were scared about that, so we wait 3 months later to maintain the same profile. And then, during this time of waiting, why not to restore all the gingival contour of the upper jaw? So we perform another surgery plus surgery. The patient saw the result, the outcome, and say, okay, why don't we do the same thing with increase the thickness and restore the gingival recession in the upper jaw? So one surgery for upper jaw to restore the gingival margin. As you can see, we resolved all the upper jaw during the healing process. During the waiting of the 3 months of the provisionalization, we changed the color to increase maybe the aesthetic demand of the patient. And then this is the flow chart that we use to explain that situation. Okay, this is again from Ramon Gomez Mea and from Jonathan Esquivel, and they use, this is when we have the gingival margin in position. And this is when you don't have the gingival margin in position, and he showed us the thin phenotype, apical position of the gingival margin, bone dehiscence, and they say, okay, we can't do it immediately, or the gingival margin, we have to wait. And this is the approach of the subcritical contour and critical contour, and how they manage the provisionalization to increase the support and the space for the tissue to heal. And then wait a little bit with 4 to 6 months, because 3 months maybe it's maybe too close to have some compression and restore the gingival margin. So we wait a little bit more. Okay, so now for 4 to 6 months we left provisionalization and start the compression to restore the gingival margin. And then the final restoration. As you can see, this is the final restoration where we restore the gingival margin, the thickness, we restore the gingival recession of the 2.2 and the canine. And you can see this is what we reach with the patient. It's very important for us that the crown have the same level in the palatal aspect, to the patient don't have some issue with the tongue when they pass the tongue in the palatal aspect of the crown. And you can see here the restoration of the thickness and restore all the merged profile of the 2.1. As you can see the before and after. The before and after maybe can reveal it itself, how we restore the gingival recession, we restore all the process of the alveolus, and the one restoration at the delivery but the laboratory was pretty well. Okay, so how this is CBCT show. This is the restoration of the bone wall, and you can see after 1 year, this is the stability of the bone wall with the implant placement. And let's check the patient with the high smile, how they look. As you can see, this is an entire restoration of the upper jaw with gingival recession treatment, with coronally advanced flap, with the immediate restoration of the gingival margin with immediate provisionalization. And let's check how the patient goes. This is maybe the summarizing what we have to keep in mind with this kind of treatment. Okay, this is for 3D position, it's mandatory. The material selection, the bone fill have to be mineralized. I always use allogenic biomaterial because of what maybe give me some support, because of the mineralization of the tissue can support the compression of the flap. Okay, the prosthetic design is important, so the macro and micro design is important, but most important here is the abutment. The abutment and bone grafting, connective tissue, and long-term provisionalization. As you can see how we resolve every situation in the stage approach with this kind of treatment. You can see the local finding, the surgical, the restorative, and of course, it's more important, the prompts, the patient outcome and satisfaction. Okay, so the patient was well, so the team of us was well. So for my message for me is things different. Maybe rethinks everything, and hope you enjoy. My name is Pablo Urrutia, and thank you all.